major risk factors are actually pretty well known to all of us. It's a lifestyle disease. And so there are behavioral factors and there are modifiable factors. So if you look at high blood pressure, diabetes, cigarette smoking, dyslipidemia, these are the 4 risk factors. And then you have psychosocial stress, you have physical inactivity, you have sedentary lifestyle, you have obesity. So that pretty much makes up a mix for not only cardiovascular disease, but also high blood pressure and diabetes. And the biggest contributors to plaque formation in the arteries of the heart, causing heart attacks and poor LV function, are actually cigarette smoking, nicotine in any form for that matter, high blood pressure, and high LDL cholesterol and diabetes are so rife here.
Yeah.
So what my concern is that despite good knowledge about these so-called lifestyle factors, which I always say there is neither life in them, nor is there any style. If we are going to ignore these factors, well, strokes, heart attacks, kidney damage will obviously follow. So these are the major factors that are contributing to the rising prevalence of CVDs in the Indian population.
So it's the whole gamut of lifestyle diseases that are responsible. Rightly put, sir. So in this context, if we have to talk about, and we should talk about, emergence of preventive cardiology, I think that's the way forward. And I'm sure seniors like you have already paved the way for it. Now, preventive cardiology, it addresses both clinical and preventive medicine aspects of cardiology at individual and also at population levels. And I think as a country, that is another risk that we are facing. To scale anything to our population level, to a community level, is another bigger challenge I think we are all facing. So, sir, if we can just throw some light on what is the role of preventive cardiology in the CVD risk aversion today. If you can just talk about that.
Yeah, excuse me.
Sure.
See, the role of preventive cardiology is central to the whole thing. When we are sitting in a hospital, we are waiting for patients to come with chest pain, and then we'll wheel them in for primary angioplasty, or we'll give them streptococcal, whatever. The main thing is to actually be able to tell the patients and the population at large that there are only 6 or 7 factors which are important, life's simple 7 as we call them. And therefore, these factors, if we try to control or not let it develop, then we will be able to prevent. Prevention is several times better than a cure. You know, this whole story, just take a minute, actually started in a small place called Framingham, outside of Boston. When after the Second World War, the then President of the United States, Mr. Harry Truman, said that too many people are dying of heart attacks. And Dr. William Kennel took up this challenge, and he identified 4 classical risk factors, which are still there. Diabetes was less there, hypertension, smoking, and dyslipidemia, LDL cholesterol being high. And that started the Framingham Heart Study. Now, ironically, this may not be truly applicable to Indians because it was made on white Caucasians, but it did focus to us that there is a field called preventive cardiology. There is, as you very rightly said, 2 very clear-cut factors to it. One, that we can start off in the hospital, and 2, we will have to go to the community and tell them, guys, don't do all this. Run on, don't put on weight, and shun these habits. I tell you, even those doctors, many of us who just want to sit in the hospital, even they can help, because once they've done an angioplasty or bypass on a person, they can at least tell their relatives, they can tell their siblings, okay, look, this was amenable prevention, and at least you all started. And there are tests that we can actually preempt and prevent and predict that the arteries are going to get thickened. So we have reached that power today. So the emergence of preventive cardiology, you've named it so well, that now if we have enough, and this need not be done just by cardiologists, internal medicine people, people in other family medicine and all, should be able to tell people,
Right. Right.
right? Right?
Yeah. Yeah.
And
There's a lot of skill gap.
smoking is so bad. Yeah. And smoking, not only are you getting the pollution from atmosphere, you're doing it yourself, and all the your nice people, your people who are close to you, you are also making them passive smokers, which is equally bad.
Yeah, yeah. Sir, I think you've raised a very right point, and for someone in your capacity to speak exactly that means a lot to a lot of people attending. We just cannot wait for only the cardiologist to address the issue of the cardiovascular burden. Like we talk about how we can't just wait for the endocrinologist to address the diabetes burden. At a primary care level, I think every physician needs to be equipped and skilled enough to at least tackle the preventive aspects of these diseases so that consultants like you can address the actual complicated cases or get into invasive more. So, sir, in this context, do you think, considering the high burden of CVDs in India, do you think there is a need for an academic program that not only focuses on clinical cardiology, but also on preventive and non-invasive cardiology? Since we have such a
Yes,
big skill gap, please.
yes. That's a good word you've used, skill gap. There is. And then people are still not thinking that we can actually put these together,
Yeah,
that preventive and non-invasive actually go hand in hand. I'll give you a very small example.
sure.
15, 20 years ago, we started just looking at the carotids of people and looking at their intermedial thickness. And this just demonstrated to us that if the intermedial thickness is elevated, which means that atherosclerosis or thickening of the arteries has already started.
Right.
This test can be done non-invasively, can be done in men and women, even in pregnant ladies. There's no radiation, and we have data now. A study called the SCORE study, which was a pan-Indian study,
G.
that we can tell people that yes, it has already started, and this is what you need to do.
Yeah.
Also, non-invasive cardiology helps us doing stress echocardiography, TMT. It helps us in doing calcium scoring. Now they say if your calcium score is zero, it is a it is a great power to tell you, okay, you can stop some of your meds. You don't need all this. So they go hand in hand. I don't want preventive cardiology people just to rattle off the data to us. We all know it. If I am an Indian, I have the highest chances of getting a heart attack in the whole world of any ethnic group. That's enough. And the data is very clear. Almost 28 to 29% of people are dying, have mortality because of coronary artery disease. Now, if you look at, just close your eyes for a second and say, look, I have 130 crore people in my land, and 30% of them have got coronary artery disease. The figure is totally mind boggling. And here is male and female, there's no difference. So you put it in a very nice way that preventive and non. I actually call it preventive non-invasive cardiology
Yeah.
because not only intermedial
Yeah.
thickness, but stress echocardiography, pulse wave velocity, flow-mediated vasodilatation. These are the early markers, and we have to go early. There
Yeah.
is once the patient comes with chest pain, then it is very clear. Okay, by what route you have to go? Have to have an echo, look at the wall motions, and go straight into the lab or do. So so this was actually the basis of starting
Program. Right. Right.
this program.
I'm sure a lot of thought
And
process has gone into this. Yeah.
yes, and more and more thinking from the last decade was cardiology is equal to angioplasty or angiography. And I've always said that, look, even though I may be one of the exponents of that technique, but I do feel that till you do not know the condition of the heart, are there any valves leaking, you don't know whether that was the right thing to do.
Yeah. Yeah.
So I think the formation of this program was with thinking that those who have done MD internal medicine or family medicine or such like, who are good clinicians,
Yes.
who can do good history, good physical examination. Physical examination is not dead. We're not carrying stethoscope just for show. We can pick up so many things.
Sure.
And then we apply the technology of non-invasive cardiology, which is not based on radiation at all. I mean, most of it,
Yeah.
leaving CT.
Hmm.
We are actually able to help the patient in many ways.
Right.
And you have it on your own.
Right, right, sir. Rightly put. So now that we understand that it makes sense to have probably an academic course or a training of this sort, there's another important discussion that we all need to address and agree. And you just made that point also that imaging it plays a very very key role in the diagnosis. So how important is the role of imaging modalities, especially if we have to talk about echocardiography in cardiology, from both
Yes.
diagnostic and also preventive aspects?
Echocardiography is actually the ears and the eyes of the cardiologist. He cannot do anything today without a good ECG and an echocardiogram. This tells him, for example, a patient comes with chest pain, very common example. Patient is clutching his chest and he comes to the, you won't rush him to the cath lab till you know what you're dealing with. An echocardiogram shows you wall motion abnormality, but very importantly, an echocardiogram rules out a pericarditis, hypertrophic cardiomyopathy, and a dissection of aorta. So they have told you that, sir, you cannot do what is called a thrombolytic therapy in these patients because they are a different group of patients. And of course, many of them who have ST elevation MI, of course, you will do it. Also, it will help us if there's rupture of some part of the heart. It's very common after a heart attack. The patient is going into cardiogenic shock. So, not only in prevention for the community at large, but also in saving lives for the patients at large of cardiology, echocardiography is a must. And I wrote an article many years ago, the value of echocardiography from the emergency room to the operating room.
Right,
And it has, lo and behold, come true. People use it from outpatients, surgeons, operating theaters, and such like.
right, right,
And things are going in such a direction that in the years to come, and not very far, far in the future, when you thrombolize a patient, the final thrombolysis will be done by bubbles or contrast. That is called sonothrombolysis. So after this interventional cardiologist done his job, comes in this gentleman, he puts the echo on, so the remaining parts are cleared off.
right.
So we are not taking echocardiography in
Yeah,
isolation or cardiology in isolation. We are putting everything together. And I think that good clinical acumen with echocardiography puts this into the perspective of the 21st century.
right, right. Very rightly said, sir. So many patients with ACS also present with comorbid conditions and other complexities attached. So this is very, very important for us to address what exactly is are the critical knowledge elements and skill elements required for any physician to gain complete understanding of ACS and its management. If you have to name the list of knowledge sets and the skill sets.
No, true. Once the patients come with ACS today, this patient may be a patient of chronic kidney disease, for example, or maybe diabetic with uncontrolled sugars, or may be hypertensive, or may have had a recent stroke. So we have to know clinically that before we proceed to any cardiovascular procedure, is it safe to do it? Supposing the patient's creatinine is 2.2, supposing the urea is 100, then we'll go a different route. If the diabetes is uncontrolled, of course, we know by drips or something we can control it. And we have to be very sure that the patient is also not having concomitantly a stroke. So these comorbid conditions can only be understood by good clinical history and examination and having your colleagues of other specialties around you to say, well, we can take care of our bit. You guys go ahead and save this patient's life because life ultimately is hard, but also you don't want to rush and then create a problem that this patient goes into dialysis.
Right.
So it's a very good question actually about what you've asked, critical knowledge. And we always post one cardiologist in the emergency room that when our colleagues in the emergency medicine have had a look, they will always call him and say, look, what takes precedence. In most cases, the heart will, but in what order?
Yeah.
Today's cardiologist is actually a internist at heart and also a cardiologist because he has to have a wide career base, a wide knowledge base.
Right, right. I think you've just beautifully summarized it, sir. That you need to still be an internist at heart to be an effective cardiologist. So I think that puts everything into perspective and why we wanted this particular audience to be a part of this discussion.